Hello, my name is Daniel de Bakker, and discussing the targets of human characterization, we need to discuss CVP in this context. Why do we need to discuss CVP? Because CVP is really a very central measurements in the patients with sepsis. And remember that the previous iteration of the Surviving Sepsis campaign used the CVP as a target of resuscitation in this context. How did we came to this recommendation at that time? Well, we have to look at the cardiac function curves. Indeed, there is some relationship between the right atrial pressure and the cardiac output. And also, when looking at the relationship between the outcome and CVP, we can also see that higher CVPs are associated with a poor outcome. So why do we come to these specific values of 8 to 12? Well, it's basically because it was used in the reverse trial that nicely demonstrated at that time the potential benefit of using early goal-directed therapy on mortality. But importantly, what was surprising is that the CVP 8 to 12 was basically used in the two arms as a first step to hemodynamic optimization. So there was no direct comparison of a CVP of 812 in one group and CVP 812 in the other group. And when looking at the meta-analysis of the different trials, it was quite obvious that globally there is no benefit from using this early goal-directed therapy, because indeed we can see here there was no difference in outcome when all trials were lumped all together. However, we still need, of course, to look critically at this evidence because the trials were not really exactly the same, because indeed mortality was much higher in the control group of the reverse trials compared to the process arise and promise. And also the target value of SCVO2 was already quite rich in the more recent trials, was it was quite abnormal in the reverse trial. And also the septic shock patients were a little bit strange in the recent trials because indeed 20% of the patients with septic shock, refractory hypotension and lactate above 4 were not admitted to the ICU and were not dying. These patients were just discharged to the ward after 6 hours, which is not really septic shock patients. So obviously, the concept may remain valid. The patient identification is crucial. When patients are deemed to go to the ward, it's definitely not needed to implement early goal-directed therapy in these patients. And the classical goal-directed therapy may still be applied when better hemodynamic strategies cannot be used. So, what is exactly CVP, and should we go for this 8 to 12? We will discuss this in more detail now, because CVP has an important role in cardiovascular physiology. It represents several aspects. It represents right ventricular function. It represents right ventricular preload. It also is affected by some other factors than volume and cardiac function. It is also affected by intrathoracic and even intra-abdominal pressures. But importantly, it represents not only cardiac function and volume, it also represents the limitation to venous return. And it is a back pressure of splanchnic, renal, and other extrathoracic circulations. So is it useful to measure CVP? Well, again, an important variable associated with outcome in different trials. So how do we interpret CVP? Well, intravascular pressures are affected by the intrathoracic intra-abdominal pressure. And if we think at a measurement of CVP of 15, what does it mean exactly? Well, we know that it is within the thorax. And if the thorax is submitted to a pressure of 10, this means that the transmural pressure will be only 5. So for the heart itself, being right ventricular preload or being right ventricular function, it's only a CVP of 5 that this patient has. If we are thinking at extrathoracic organs, then the 15 millimeter mercury is a true pressure that these organs are living as a back pressure for the kidney, the brain, and others. So really, it is an important, very important variable. But of course, for evaluating the cardiac function and especially response to fluid, it may not be the best in these conditions. However, again, for the back pressure, venous return, and for these other organs is very important, very relevant. It is relevant for peripheral edema. It is relevant for the development of intra-abdominal pressure. It is relevant for the liver congestion. And we know that here, the higher the CVP value, the higher the risk to develop acute kidney injury. Well, quite interesting to measure then, of course, CVP, and when we will discuss target, to try to prevent having or reaching excessive values is also very relevant. And non-measuring CVP is going blindly in these conditions. So can I use CVP to guide fluid resuscitation? Yes, I use it for this. Well, let me say, okay, it does not predict very well the response of fluids, and we can agree with this. But we should not go in this direction, stating that we should stop to use and to measure CVP because it has no role in making clinical decisions. This is totally false. We can use it for this. And this is what we developed in that paper, because indeed we can use it. Is CVP 8 to 12 the best target? Yes and no. Well, of course, obviously, what we can say is that when we look at the response of fluids according to central venous pressure, when it is very low, most patients respond to fluid. When it is very high, most patients do not respond to fluid. And in between, we have an unpredictable response to fluids. When we look at data, we can see that 5 to 6, yes, below 5 to 6, most patients respond to fluid. Above 15, most patients do not respond to fluid. And in between, all the response is quite variable. When you look again at this variable here, above 8, well, most patients did not respond to fluids. And indeed, many data, many trials look at that, and below 6, most patients respond to fluid. Above 14, most patients do not respond to fluid. So the negative predictive value when we have a high CVP value and the positive predictive value when we have low predictive value are quite good, and so we can still use these variables to measure and to guide resuscitation. So the way I use it is that I consider that the proportion of responders to fluid markedly decrease by increasing CVP, and the risk associated with fluids increase sharply by increasing CVP. So when I face a patient with a low CVP, I know that this patient has a relatively good chance to respond to fluid. And by the way, even if I fail, the risk associated with fluids are minimal in this condition. So I may test fluid in these conditions. However, when CVP is high, it's just a reverse. The risk associated with fluid is very high, and on the other hand, the responders are very low. So I should prevent giving fluid, because even if they respond to fluid, the risks are too high. And of course, in between, well, I have to use something else to try to predict the response of fluids. And also, I know that reaching relatively low values of CVP between 8 or 12 is not associated with an increased outcome. It is when I reach higher values that indeed is associated with an increased outcome. Is the increase in CVP indicative of the response of fluid? Definitely no. The increase in CVP is just associated with an increase in the preload. That's it. It does not reflect the increase in the preload in this condition. So the increase in CVP is a price to pay, not a goal in itself. And this, of course, is just basic physiology. And so we do not expect from the changes in CVP to predict the changes in cardiac output, to predict the changes in arterial pressure. It is just basic physiology. Can I use CVP as an indicator of tolerance of fluids? Yes, indeed, because when I give fluids, I increase the volume of the heart, but then when the heart becomes dilated, the pressure is increased markedly and the volume doesn't change. So yes, I can indeed use it. And that's why for fluid challenge, we use this CVP to try to assess safety and effectiveness of volume. Safety, because indeed I use CVP to stop fluid challenge when there is a marked increase in CVP above a limit I consider too high for my patient. And I evaluate the responsiveness to fluid. When there is an increase in cardiac output, I know there is a positive test. But when I see an increase in CVP without any change in cardiac output, I know this patient will not respond to fluid, and it's time to stop to give fluids to this patient. Is there some impact on outcome by measuring CVP? Well, these are important data looking at patients in which CVP is measured compared to other patients where CVP is not measured. And you can see that the hospital mortality and even 1 year mortality is definitively lower in patients in whom CVP was measured. So we should measure CVP and pay attention to the measurements to guide the resuscitation of these patients. So at the end, CVP is a meaningful physiologic variable. Its measurement is associated with an improved outcome in sepsis. CVP reflects the risk-benefit ratio associated with fluid administration. It does not predict nicely the response to fluid, but it reflects the risk-benefit to fluid. And just for this, it's just very important to measure CVP. For many patients, statistically speaking, values between 8 and 12 may be adequate, but the optimal value vary for each patient. So we need to individualize the fluid therapy, but again, paying attention to CVP, because higher CVP values may still be associated with some response to fluids, but at the end, the price you pay with fluids will be higher when CVP will be higher in these patients. And with this, I thank you for your attention.